Hi viewers, my name is Dr.Phani Krishna Ravula, and today we're going to discuss about pouch surgery. So there are some conditions of the intestine in which the entire large intestine has to be removed. The entire large intestine, basically you have four parts: ascending colon, transverse colon, descending colon, and rectosigmoid. In certain diseases which of the large intestine, like such as ulcerative colitis and adenomatous polyposis, these kind of conditions, the entire large intestine has to be removed, and the job of the large intestine is to make your stool solid. So by the time in the small intestine, about a liter of liquid stools come to the small intestine, and the large intestine makes them sort of semi-solid and solid by absorbing the water. So when you take out the colon, the absorption function of the large intestine is lost, and then you're depending only on the small intestine, and either you have to bring it outside like a bag and be on a permanent stoma bag with the stools collecting on the abdominal wall, or if small intestine is connected to the anus, you'll have a lot of stool frequency, around 15 to 20 times a day. In this kind of a situation, when you want to remove the entire large intestine as well as avoid a stoma, we do something called pouch surgery. We create a pouch with the small intestine so that the small intestine takes over the absorption function of the large intestine, and despite having this entire large intestine removed, the patient can still hope to pass normal stools. Basically, the pouch surgeries we do are mainly for the upper GI and the lower GI. In the upper GI, when we remove the entire stomach, we do something called a Aunt Lawrence pouch, so that when the whole stomach is removed, the reservoir capacity of the stomach is taken over by the intestinal pouch, so that you can eat more in one go. Mainly in terms of the pouch surgery for colon, when we remove the entire colon in diseases like ulcerative colitis or familial adenomatous polyposis, in that situation, the types of pouches are dependent on their shapes. The J pouch, S pouch, W pouch, they have some minor advantages, disadvantages, but most of the time patients, we have over the years, we do the J pouch because it's the simplest pouch, which is easy to perform, and results are as good as the W pouch and the S pouch. So most of the time the pouches surgery we do after colon colectomy, total colectomy, is the J pouch. The pouch surgery basically is, most of the time we do it laparoscopically, minimally invasive, without a scar. The surgery is sometimes performed in two stages. So first stage, we remove the entire large intestine, construct a pouch with the small intestine and attach it to the anus, but till the healing occurs, we do something called a temporary diverting ileostomy. The intestine is temporarily brought out to the abdominal wall for 4 to 6 weeks, and once the healing of the anastomosis downstream, all the healing has occurred, then we close this ileostomy. That's called a two-stage pouch surgery. And sometimes when the patient is very sick, the patient is sick because of some emergency condition or is nutritionally very poor, then we may do a three-stage pouch surgery. That means in the first stage, when the patient is very sick, we just in emergency we remove the large intestine. In the second stage, we make the pouch and have a diverting ileostomy, and in the third stage, we close the ileostomy. This three stages, especially in patients who are on a lot of immunosuppressive medication, sometimes especially the ulcerative colitis patients are very sick, so we can't do such a major surgery in one go. But essentially, in most centers, including ours, the surgery is performed by laparoscopy, keyhole surgery. Of course, to get the specimen out and create the pouch, we may make a small, around 4-5 centimeters suprapubic incision. The indications of pouch surgery are mainly two. One is in case of intestinal polyposis syndromes. Basically, you have the most common is of course familial endomatous polyposis, in which basically the patients get polyps by the time they are 20, and majority of them develop cancers by the time they are 30. The other polyposis syndromes such as Peutz-Jeghers polyposis, juvenile polyposis. In all these polyposis syndromes, basically the entire colon gets involved by multiple polyps because of genetic mutations, and once these polyps occur, they can cause several problems including malabsorption, diarrhea, abdominal pain, and transform to cancer. So once patients have polyposis syndromes, we would sometimes need to remove the entire colon to treat the polyposis syndromes, and they would need a pouch surgery. Another situation where we commonly do pouches in ulcerative colitis. Ulcerative colitis is basically a condition in which there is inflammation of the large intestine, which presents with severe diarrhea and blood in stools and other systematic manifestations like joint pains, liver involvement, and many such issues. In ulcerative colitis patients, basically if they don't respond to medication, so in ulcerative colitis patients we have first line medication is steroids, maintenance is mesocol, azathioprine. Second line medications are monoclonal antibodies such as infliximab, adalimumab, and then you have drugs like tofacitinib. So patients who are not tolerating these, not responding to this medical management, or patients who respond to the medical management but on stopping this medical management, they immediately the flare up occurs. So those kind of patients, basically once you stop medication, if immediately the flare up is occurring, you can't continue these medications lifelong, because all medications, steroids, infliximab, they have a lot of side effects, and they're not for long term. So if the patient is dependent, steroid resistant or medication dependent patients, these kind of patients we should consider a surgical therapy. Likewise, there are some patients who are not tolerant to medication. The patient has some contraindications like some hepatitis B, hepatitis C, or some other reasons where immunosuppressive medications, all these medications suppress immunity. Basically all the medication used for ulcerative colitis are mainly immunosuppressive medication, be it steroids or monoclonal antibodies. So if the patient is not responding to the medication, or patient is on the medication and the moment you reduce the medication, patient is flaring up, in that case basically you can't continue the medication lifelong, because they have a lot of side effects, all these medication. From pretty serious side effects like steroids can cause sugar, BP, make your bones weaker, and put on a lot of weight gain, water retention. Likewise, infliximab, they affect your wound healing. They can lead to flare up of tuberculosis. They can cause reactivation of underlying virus infections like varicella, herpes zoster, hepatitis B, hepatitis C. So for a lot of reasons, patients are either intolerant, they are unable to take this medication, they are not responding to this medication, or they are dependent on this medication. That means the moment you stop them, reduce the dose of medication, disease is flaring up. So in these three groups of patients, they need pouch surgery. And then there's one more group of patients of acute severe colitis, in which sometimes the inflammatory bowel disease, ulcerative colitis or Crohn's, comes as a very severe disease. I mean, a very severe disease with patient comes with severe diarrhea, abdominal distension, something we call toxic megacolon. In those patients, again, we try medical management. If the medical management doesn't succeed, they would need surgery. Likewise, in patients with ulcerative colitis, once they develop precancerous changes, severe dysplasia or cancer, we would need to remove the entire colon and do pouch surgery. Well, basically, pouch surgery is not done in certain cases, like patients who are too frail and weak to tolerate a major surgery. We would not like to do pouch surgery for them. Patients who have sphincter problems, like a lot of anal sphincter tone is poor because of old age, they can't go to the toilet frequently, and mainly bedridden patients, better to just do a permanent ileostomy and avoid a pouch. Then patients with lower third rectal cancer, where the colon cancer is actually inside the lower third of rectum, we avoid a pouch. Likewise, in patients with Crohn's disease, it's better to avoid pouch because the complication rate is more. So basically, in diseases like ulcerative colitis or edematous polyposis, you're removing the entire large intestine. So the water absorption and making the stools from liquid to solid is the main job of the colon. So if your entire colon is removed, you'll go to the toilet 15 times, 20 times a day, which is impossible. So doing the pouch, it takes over the water absorption capacity and make sure that you go to stool frequency less commonly. So initially the patients after surgery, they go to stools 5 to 6 times a day, but over a period of 6 months to 1 year, they would normally go 2 to 3 times a day. Of course, this differs. Outcomes vary in familial edematous polyposis, in which polyposis cancer surgery, the results are better, while ulcerative colitis, some of them can have recurrent inflammation of the pouch, which will lead to slightly increased frequency. The other main benefit of the pouch is you're disease free. Like in FAP, you're cured of familial edematous polyposis. Any polyposis syndrome, your colon is taken out and you're cured. Likewise, in ulcerative colitis, lifelong you're on medication. You don't know when the flare up is going to occur. After 7 to 10 years, ulcerative colitis can turn into malignancy. So, and you have to take all the steroids or the immunosuppressive medication with all their side effects and risk factors. For ulcerative colitis and familial edematous polyposis, the pouch cures the disease and also make sure that you can have a good quality of life in terms of passing stools not too frequently. You can do your office work, you can go work, job, swim, anything you want, and avoid a permanent ileostomy. A pouch surgery is a complicated surgery should be done only by experts who have a lot of experience in that area. The main this thing for any major surgery, it's a major surgery, so like the normal cardiac respiratory problems for many major surgery. But in the short term, the main pouch specific complications, one would be the pouch leaks. I mean, because when you construct the pouch, the suture line can leak and lead to pelvic abscesses, anastomotic strictures, infections, and in women, in young women, when you do the pouch, they can, because the fibrous in the pelvis, you can have fertility issues. These are the usual short-term problems. The long-term problems are not really seen in all the pouch patients. In fact, in adenomatous polyposis patients, you'd hardly see. In patients with ulcerative colitis, you can have something called pouchitis. Basically, the inflammation of the large intestine, which the patient had all these years, can become inflammation of the pouch. So this can be a short-term acute pouchitis, which usually responds to antibiotics and probiotics, or in some patients you can have long-term chronic pouchitis. This leads to increased stool frequency, blood and mucus in stools, hemoglobin dropping, anemia, and all these issues. So, but these chronic pouchitis problems are usually seen in ulcerative colitis patients. Well, I mean, after pouch surgery, actually the patient can get onto a completely normal diet, eat and drink like any normal person. Generally, what we do is, in patients who are having the pouch, results are variable. In some patients, they can have very good results with stool frequency of 2 to 3 times a day. In some patients, they may have around 4 to 5 times a day. Like I said, it also depends on the technical aspects, how big the pouch is and how it's healing and all that, and also most importantly the disease factors. Like in patients for cancer and polyposis, they have usually excellent outcomes. They bypass 2 to 3 times, while ulcerative colitis patients, they can have some recurrent inflammation in the pouch. So in patients with increased frequency, we tend to ask them to avoid roughage, a high fiber diet, and have a low fiber diet of easily digestible foods. In addition, there are anti-inflammatory diets of specific diets which are supposed to reduce the inflammation of the gut and all that. But honestly speaking, there is no good quality evidence to support those diets. Mainly in patients with increased stool frequency after pouch surgery, we ask them to reduce the roughage. I mean, the fiber content in that, the fruits, the salads, greens, fiber content has to be reduced. That is the main restriction. We tell that too only for patients with increased stool frequency. If stool frequency is normal 2 to 4 times a day, there is absolutely no need to have any dietary restrictions of any sort. I mean, usually after pouch surgery, it's a laparoscopic surgery, so we usually do a covering stoma, so the recovery is very quick. The patient can go home within 4 to 5 days. We usually retain the catheter, Foley's catheter, for 5 days, but patient is usually home within 3 to 5 days at the maximum. and then when the pouch surgery, the ileostomy closure, the second stage of the surgery, again 3 to 5 days. That's it. But initially, after the pouch is closed, obviously, like I said, there is some time for adaptation. You will go to stool frequency around 7 to 8 times a day, and then this gradually improves over a period of time. The long-term outcomes of pouch depend if the surgery, how well the surgery went technically, how the surgeon meticulously followed the principles of surgery in terms of the pouch size and doing the anastomosis as low as possible, avoiding injury to the nerves during the surgery, and all those factors. Of course, most importantly, also on the disease. Pouch results are excellent in familial endometritis polyposis. So in polyposis and cancer patients, once you do the pouch surgery, you don't have to worry about anything. The long-term outcomes are excellent. But on the other hand, if it is pouches done for ulcerative colitis, about 1/3 of these patients, in the long run, they may have something called pouchitis. So there is recurrent pouch inflammation can occur, and it can present with increased stool frequency, blood in stools, and anemia. So this, of course, when 1/3 of the patients, majority of them respond to antibiotics and probiotics, but a certain group of patients can have chronic pouchitis. That's a long-standing inflammation of the pouch. In those patients, which usually occur only with ulcerative colitis, not with adenomatous polyposis, in those kind of patients, we would also try to manage them with antibiotics and probiotics, and sometimes they may have to go on to immunosuppressive medication. Thank you.